One of the greatest challenges in scalp surgery is reconstruction after aggressive tumor removal. In our early experience with clinoidal meningiomas, nearly 30% of patients develop postoperative pseudomeningocele after Simpson grade 1 resection. In this video, I demonstrate the superfascial temporalis flap, a vascularized reconstructed technique that completely changed our management of this scalp-based defect. Since introducing this flap into our practice at Geisinger, pseudomeningocele has essentially disappeared from our series. I'll show the surgical anatomy and the key technical nuances behind this reconstructing strategy. This is an older patient with progressive visual loss and a right clinoidal meningioma involving the anterior process and optic canal, associated with marked hyperestosis and severe narrowing of the optic canal. Given the involvement of the optic canal dura and anterior medial fossa, a large skull-based defect was anticipated. Therefore, a vascularized superfascial temporalis flap was planned for reconstruction. The patient is positioned supine with the head slightly hyperextended and rotated less than 15 degrees. The frontotemporal region is prepped and draped in a standard sterile fashion, and a frontotemporal excision is made approximately 1 cm behind the hairline. After inferior reflection of the skin flap, the periosteum gallia and temporalis fascia are incised posteriorly. The flap is then sharply dissected from anterior to posterior. A penfield number 1 is used to perform subperiosteal dissection above the superior temporal line. At the level of the superior temporal line, the periosteum is sharply incised to maintain the gallia and periosteum in continuity over the temporalis muscle. Once the interfascial and epiphyseal fat pads have been identified, the superficial layer of the temporalis fascia is incised and incorporated into the superficial flap. We then use 4 Neuralon sutures and rubber band for dynamic retraction of the flap. Special attention is then paid to preserve the interfascial fat attached to the superficial flap, as this protects the frontotemporalis branches of the facial nerve. The superficial layer of the temporalis fascia is not always easy to identify. However, the interfascial fat pad is usually well visualized, particularly around 4 cm posterior to the orbital rim, making this an important anatomical landmark during flap harvesting. The superficial flap is retracted inferiorly until the orbital rim is exposed. Monopolar electrocautery is then used to detach the temporalis muscle from the superior temporal line. Using a penfield dissector, subperiosteal dissection of the temporalis muscle is then performed to preserve its vascular supply. The temporalis muscle is reflected inferiorly to allow for a mini-pterional craniotomy and a more anterolateral access. Here we can appreciate the harvested superficial flap with preservation of the superficial temporalis artery vascular supply. A small mini-pterional craniotomy performed below the superior temporal line is often all you need for this kind of tumor. After the mini-pterional craniotomy, the sphenoid ridge is drilled flat to the level of the orbit. A diamond drill is used to skeletonize the lateral orbital wall, and once the meningo-orbital band is identified, a standard mini-peeling technique is performed to expose the lateral wall of the cavernous sinus. Hemostasis of the lateral cavernous sinus wall is achieved using flow seal and gentle compression. We then proceed and extend an extradural anterior clinoidectomy and decompression of the optic canal using progressively smaller diamond drills. The superior wall of the optic canal is removed, followed by complete removal of the anterior clinoid process. Before tumor resection, the optic sheath is widely open. Using a microsurgical blade and microscissor, the falciform ligament is sharply released to decompress the optic nerve and avoid tethering during tumor manipulation. By doing this maneuver, the optic nerve is fully decompressed prior to start the manipulation of the tumor. The dura is then opened over the frontotemporal region and sealed in fissure. Margins of the tumor along the dura are localized to include the tumor specimen as well as the dural attachment. At this point, the tumor is fully devascularized through the extradural approach, allowing for a safe microsurgical resection and gross total removal. Following tumor resection, a large scalp-based dural defect remains and primarily watertight closure is not achievable. Then a dural substitute is first placed in an inlay fashion, and the previously harvested vascularized superfascial flap is then rotated over the reconstruction site. Several sutures are used to secure the flap to the surrounding dura. After copious irrigation, closure proceeds in a standard fashion. The bone flap is secured using titanium plates and screws over the vascularized flap. The temporalis muscle is then repositioned anatomically and reattached to the superior temporal line. Finally, layer closure of the skin is performed using interrupted 3/0 vicro sutures and running 3/0 monocryle for the skin. Postoperative MRI shows gross total resection with enhancement of the vascularized flap in appropriate position. The patient was discharged on postoperative day 1 with improvement in vision and no evidence of cerebrospinal fluid leak or pseudomeningocele at follow-up. Thank you for watching. If you enjoy advanced scalp-based anatomy, microsurgical techniques, and operative nuances, consider subscribing to the channel for more operative videos and surgical education content. Thank you and have a nice weekend.